students put their responses on the chat, with regard to whether they thought their class representative was tall. Most of them indicated in the affirmative on the chat that yes, she is tall, yes, she is tall. I saw all those responses flowing through. A few of them, however, gave different views. One student wrote, "It depends. It depends on who we are comparing her with." Another went further and said the class representative's height is relative to who we are comparing her with. So that word, "it depends," became very important. And when we transfer this now to the lab, because we are not talking about height in the lab, when we transfer this to the laboratory, we begin to appreciate that the main product from clinical laboratories is data. And this data, studies have shown that up to 70% of medical decisions are based on this data. If that is true, then that word, "it depends," becomes very important in how this data is utilized to make decisions on patients and also to make public health decisions. And it is in this context then that I'm very happy to bring to us Professor Omuse to come and shed light on issues which can clear for us this word, "it depends," when we are now interacting with the main product from clinical laboratories, particularly considering that a significant portion of the laboratory data is quantitative or numerical, so that we are not having yes, no answers. And so that data can then become very important in how decisions then are made for particular patients, and decisions which then can inform policy. Dr. Omuse, actually I should say Professor Omuse, is an associate professor at the Aga Khan University, Kenya. He is an alumnus of 4 universities in Africa. I know probably those of you who know Omuse at least know the 3 universities that he's an alumnus of, but he's also an alumnus of a 4th university I will mention. His first undergraduate degree was obtained at the University of Nairobi, so he's an alumnus of UoN. His secondary degree was at Aga Khan University, and his doctorate was obtained from University of Stellenbosch, but he's also an alumnus of Strathmore University. And those who want to know what he studied at Strathmore, you can Google his profile to find out what Dr. Omuse studied at Strathmore University. So he's an eminent alumnus of 4 prominent universities in Africa. Dr. Omuse is well able to talk about this, the topic for today, because this was exactly his doctorate research. And so it is with great pleasure that I present to ourselves Geoffrey Omuse, who also happens to be the chair of the Kenya Association of Clinical Pathologists. Dr. Omuse, kindly welcome. We're looking forward to hearing from you.
Thank you very much, Prof. Amayo. For a minute, I was not sure whether it is me you are introducing. And I really must say that if I have seen father, it's by standing on the shoulders of giants. And you are certainly one of those giants on whose shoulders I have stood on, because you taught me in undergraduate. And so to be sharing this platform today with you is really a great honor. So I don't know whether you're able to see my screen.
Yes, we can see it.
And am I clear?
Yes, your audio is a bit faint.
Oh, it's a
Maybe
bit faint.
your microphone.
Hello, is that any better?
Yes, it is.
Great, fantastic. So thank you very much, Prof, for inviting me to make this presentation that I've titled Defining Normality, a Lab's Perspective. And indeed, as you've mentioned, this basically touches around an area that I have had interest over the past few years. And when you requested me to make a presentation, naturally, I did choose a topic that I'm quite familiar with. And I was a bit shy about titling my presentation, A Talk on Normal Ranges. Given that I'm making a presentation on a Friday night at 7 p.m., the last thing that I'm sure people would want to listen to is a talk on normal ranges. Because of COVID, luckily, people don't have much else to do. And listening to a webinar on a Friday night is probably one of the coolest things one can do. So I am indeed honored that we have over 400 participants listening to a talk on normality. I'm sure this wouldn't happen in ordinary time. So to get right into it, trying to define normality, as I learned during the course of my PhD, is not as easy as one would imagine. And as you rightly highlighted, every day laboratories are churning out millions of results, quantitative results, and these results are being interpreted. And one would like to assume that the recipients of these laboratory results are making correct interpretations based on reference intervals, as I call them, or normal ranges, as many people do call them, that are relevant to specific populations. And why that is important is because we know for a fact that populations differ across the world. And some of the reasons why populations differ is because of genetic diversity, environmental influences, so including things like nutrition, altitude, and basically even population demographics. And one thing that we in the science of reference intervals struggle with when trying to define ranges that then can be applied in populations in general is trying to define the perfect reference individual who then serves as a reference from whom we will derive values. So oftentimes in health, we talk about normal when we are referring to people who we think are healthy. But defining health then becomes a very complicated issue. And so we do struggle when trying to define reference individuals and by extension reference populations as to who then should we recruit when coming up with these ranges. And I'd like to take all of you through a very small exercise. Kindly locate the chat box or the Q&A box and tell me if you are a laboratory professional and you're asked to come up with normal ranges for, say, sodium, and you are told that you have one choice to recruit a population similar to the four populations, to the four people represented in this slide, who would be the ideal adult male that you would want to use as a reference, and that any deviation from that person then should be an expression of that which is abnormal. So your choices are A, top, probably the most elite athlete in the world. B, probably the most elite politician who declares himself as very fit and probably the most intelligent. C, an up-and-coming professional who doesn't exercise much, but considers himself very healthy relative to his colleagues. And B, these Maasai Morans who spend the better part of their day walking cattle in grasslands, but who consume a significant amount of meat every day. So you can just go to the chat box and tell me which of these four individuals would represent an ideal population as far as you're concerned, from whom then you would like to derive normal ranges or reference intervals, as it were, for sodium. So I'll just pause for 10 seconds and just we will look at your responses. I can see people talking about D, A. Someone bring. C, D, C. Yeah. Someone has said consider all of them. Someone has said none. Someone has said impossible. Interesting. Very interesting. So clearly, if I was to ask all of you to carry out a study to define what normal is for sodium, you would actually recruit very different populations. I really don't know what the correct answer would be, but I'm flattered that a few people have selected C as the ideal healthy population. So C is actually myself, and I believe probably my students are supporting me by picking that option. Now, from a medical perspective, what would you define as normality? If I said I am healthy, where healthy is meant to define what is normal, then am I healthy because I feel that I'm healthy? Or does healthy mean the absence of overt disease? We know very well that you may feel healthy, but you could have subclinical disease. And that is one of the challenges you'll have anytime you set out to define reference intervals from any population, because however hard you try to come up with a perfect criteria to define who you need to include and whom you need to exclude, there's always that risk that some of the individuals you will include may have subclinical disease. So when conducting reference interval studies, how do we go about conducting them? So for starters, we do have a general population, and it's from this general population that then we will derive what we call a reference population. Now, to get your reference population requires that then you come up with a very, very clear inclusion criteria of people who you think then would serve as an ideal population to determine what is normal. And once you've identified this population, then the next exercise then is to try and randomly select representatives from this reference population. And this is what we're referring to here as a reference sample group. And so ultimately, these are the people who you recruit, collect your sample, depending on whatever it is that you want to measure. And based on the data you get, you will then go through some statistical treatments, and eventually you will have your reference intervals that then you'll be able to apply to the population. Now, it may sound easy, but it's actually not as easy, because you might agree, for instance, on what population you're identifying as being ideal, but there's so many other aspects towards deriving a reference interval that may affect whatever it is that you come up with as your ranges. From pre-analytical issues, I've already alluded to identification of reference individuals, but simple things like delays in processing samples may actually impact on the results that you obtain. Yesterday, I was in a discussion and someone was presenting a topic on parathyroid hormone and giving us the prevalence of secondary hyperparathyroidism, but never told us how long the samples stayed before they were analyzed. We know that parathyroid hormone probably has a half-life of around 4 hours. So if someone delayed by 48 hours before they analyze the sample, you'll have significantly lower values than the values you'd have obtained if you analyze the sample immediately. So if you were deriving reference intervals for parathyroid hormone and you delayed in separation of the sample and analyzing it, or you didn't store it in an ideal temperature, if you're going to delay the analysis, then you will end up getting erroneous results and by extension, erroneous reference intervals. Analytically, not all assays are the same. And what do I mean here? If you measure a hormone like thyroid stimulating hormone on Roche equipment and measure the same sample on a Beckman equipment, measure the same sample on a Siemens equipment, you will not get the exact result. And this will be a combination of analytical specificity of the assays, as well as inherent variation in the different assays. It is important to ensure that quality control is spot on, because if your quality control is not good, then you might produce results that have certain biases. Post-analytically, even from the same set of data, depending on the statistical tool you use to derive your reference interval, you could end up getting very different ranges. And generally, broadly, we speak about parametric and non-parametric, depending on the distribution of your data, and just that decision, what statistical method will I use to derive my ranges, will actually have an impact on what you eventually come up with as your definition of a normal range or a reference interval. Now, globally, what is recommended is that every laboratory needs to derive population-specific reference intervals. But in reality, that doesn't happen, especially in sub-Saharan Africa. For those of you who work in any healthcare setting that has a laboratory, I challenge you to walk into your lab and ask them, for instance, where do they derive their reference intervals for hemoglobin or your complete blood count or any routine test that they do. And I can almost assure you that most either get their reference intervals from published articles, but more commonly from reagent inserts or standard textbooks. The question to ask is, where did those values come from? Are they derived from an African population similar to you? And how appropriate are they to interpret values derived from patients in your locality who visit that laboratory? Indeed, use of inappropriate reference intervals can lead to misinterpretation, can lead to misdiagnosis, which can also contribute to either over or under investigation. Now, do we have data from Africa on what sort of defines normality in our sub-Saharan African population? And the answer is yes. We do have many studies that have been published across many of the countries in sub-Saharan Africa, but there is paucity of information on the pediatric population and, of course, pregnant women. We know that these are largely considered vulnerable populations, and even ethics committees may have an issue approving studies to be carried out in these populations. Many of the studies are from healthy adults, but there's a lot of question around the published reference intervals, especially those that were derived during the era when clinical trials for HIV were in vogue. Because by and large, what often used to happen was that volunteers for clinical trials who are found to be HIV negative would then be assumed to be healthy individuals, and from whom then they would run these tests and calculate normal ranges. And people have critiqued many of these studies, mainly by arguing that people who volunteer themselves for HIV clinical trials may not necessarily be the best representation of the general population. And we can get into some of those details. Now, I'm projecting for you a study that was done several years ago, and some of the people who are involved in this study are actually faculty in University of Nairobi. And this is data from a study that was carried out in 4 African countries in East Africa. I think it was Kenya, Uganda, Rwanda, I think Malawi, I'm not too sure. And I've highlighted for you some in red, some of the ranges, which if you compare to a Caucasian population, and in this case, an American population, there are some significant differences. If you look at hemoglobin in females as an example, you can see the lower limit of hemoglobin in what was reported as a healthy population of adults was 9.5. I know many of you will argue that based on the WHO cutoff of 11, these women, a number of these women were anemic. The lower limit for hemoglobin in this particular study is much lower than the 12 that is used in the US. If you look at the mean corpuscular volume here, look at the lower limit again, is for females, especially is 68. This is actually combined males and females compared to 80 in the US. So one would say, perhaps a number of the participants here might have some form of microcytic anemia. If you look at the neutrophil count and look at the lower limit, you will note that in this population in East Africa, the lower limit of the neutrophil count and even the upper limit are much lower than what the US, people in the US are using. And this has been an issue, an ongoing debate. This is not new. It is known that Africans have what is referred to as a benign neutropenia due to certain genetic changes related to the Duffy antigen receptor chemokine. And the reason why this is important is that if you are following up a neutrophil count to decide whether somebody has an infection or has neutropenic sepsis, chances are that you could end up overdiagnosing the same. Now, I have challenged many of my colleagues, why do we still insist on using higher neutrophil count reference intervals, yet we know very well that is not the reality for our population. If you look at the eosinophil counts, the upper limit of the reference interval is higher, and one might argue that, perhaps this population had parasitic infections or they had some allergic reactions. We do not know. But many questions then arise when you start seeing some of these differences. And one of the questions you'll ask yourself is, do these differences reflect a variation of normal, or do they reflect the presence of disease? If I look at a few of the chemistries, and I must say that most of these findings have been replicated in a number of African countries, what really stands out, for instance, is the upper limit of total bilirubin here of 37 compared to the upper limit of 17 from an American population. Now, we'll have a discussion about this later on, but clearly this is a significant difference. It is almost 2 times the upper limit of normal for the American population. If you look at the upper limit for the total immunoglobulins, again, this is much higher compared to the US-based comparison interval. So you will agree with me that it appears that there are significant differences for certain parameters, not all of them, And potentially, this could result in misinterpretation of laboratory data if you adopt reference intervals that are not specific to your population. Now, I have done a little work around reference intervals, and one of the things that I have looked at, for instance, is reference intervals for thyroid function tests in neonates. Now, where I work, we do have a program for screening for congenital hypothyroidism, and TSH and free T4 are the commonest tests that are requested. But if you know something about congenital hypothyroidism, the actual incidence is about 1 out of almost every 5,000 live births. So invariably, if you test 5,000 neonates, chances are that you only pick one neonate who has congenital hypothyroidism. So lab data is then a good source for deriving reference intervals for neonates. And so what I'm showing you here is trying to compare the reference intervals for up here, this is thyroid stimulating hormone, what was provided to us by the manufacturer of the equipment, which is Roche, and what we derived from our own population of neonates. So this is comparing 0 to 6 days. This is comparing 7 to 90 days and 7 to 30 days. And clearly you can see in terms of upper limits, our upper limit was much lower compared to what Roche recommends that we should be using. Similarly for free T4, if you look for 0 to 6 days, our values look to be higher, and basically emphasizing the point that you cannot just copy and paste what you're given by a manufacturer and assume that whatever values you're given are ideal for your population. Few studies, I know I said there's a paucity of data from pregnant women, but there is a study published from the western part of Kenya. And again, I'm highlighting in red certain differences between Kenyan population here and an American population of women. So you can see like the upper limit of the transaminases are a bit higher in the Kenyan non-pregnant women. If you look at the bilirubin, this is still persistent, that the upper limit is still higher. And the other thing you note is that throughout the course of pregnancy and in the postpartum period, there are significant changes that happen. Now, I don't know how many of you have laboratories that when reporting lab tests for women attending antenatal care, actually give you gestation-specific reference intervals. Down here, you can see platelet counts, not surprising during pregnancy, especially in the postpartum period. They actually increase. We know that platelets thrombocytosis can be reactive. So this might not be very surprising. Now, given that most labs will never attempt to come up and calculate or determine their own reference intervals, what are the options? Now, a laboratory body in the US that we refer quite a bit to, known as the Clinical Laboratory Standards Institute, tells you that if you're unable to establish your own reference intervals, the very least you should do as a laboratory is to at least verify that what you've been given from the textbooks, from the manufacturers, is ideal for your population. And a simple way of doing that is get 20 healthy people, because this will be subjectively healthy, like blood donors, run samples from 20 of them, and if at least 18 of the 20 fall within the range that has been given you by the manufacturer or the textbook or the manuscript you're using, then you may assume that then those reference intervals may suffice for your population. Now, I have been involved in a global study that was attempting to determine reference intervals for selected tests across the world. And in Africa, 3 countries were invited to participate, that is Nigeria, Kenya, and South Africa. And I happen to be the project lead for the Kenyan part of the study alongside Professor Amayo. What was important about this study is that a lot of effort was put in to try and standardize pre-analytical, analytical, and post-analytical processes, so that ultimately people then would try and compare and determine whether indeed there are significant differences across different jurisdictions. In our attempt at defining a healthy population, at least for the Kenyan part of the study, we had a fairly elaborate exclusion criteria. I know someone might argue that this exclusion criteria is too loose in terms of allowing us to incorporate people who take 4 drinks a day as being healthy, but I will accept that criticism and probably engage on this later. The point being that whatever criteria you come up with to include or exclude will always fall short depending on what somebody's expectation, what somebody's definition of what is a true representation of health is. So we went through this process. We recruited over 500 people across 4 counties. And one of the challenges that we faced after collecting the data and doing the analysis was trying to figure out, in as much as everyone who presented themselves for the study, including a good population of undergraduate students from the University of Nairobi, we began asking ourselves, the population, the reference population that we recruited, how representative was it of a healthy population? So when we started analyzing the data, one of the things that popped out was that a quarter of the population had metabolic syndrome. And this was a bit surprising to me. The WHO actually says that the prevalence of metabolic syndrome is around 25%, and that it is increasing, especially in Africa, in sub-Saharan Africa, because of urbanization. Now, one question I know you would ask me is that if a significant proportion of the people whom you recruited as being healthy had metabolic syndrome, and we know that metabolic syndrome is a risk factor for cardiovascular disease and type 2 diabetes, then how sure are we that you truly had a healthy population? And why should we believe the results you gave us, that this defines reference intervals for our population? Now, you might want to ask me, what is the relationship between metabolic syndrome, or say something like BMI or body mass index, and reference intervals? Now, as I mentioned, we had several countries participating in this global study. And what I'm showing you here is how BMIs varied across males and females for some of the participating countries. Not surprisingly, the people with the lowest BMIs were the Asians. So this is China, Japan, Philippines. And the people who had the highest were people from Saudi Arabia. Here, ZA is South Africa, and the AF is Africans, and this is the non-Africans. And you can see how BMI varied across both males and females across all the countries. Now, why is that important? That is important because based on this data that I'm showing you, we know that certain values for certain tests vary significantly across different BMIs. And not only that, the rate of change is also different across different countries. So for instance, this red line here is from Japan, and you can see that with increasing BMI, the rate of decline in HDL is quite high in Japan compared, for instance, in Turkey, where with the increase in BMI, there isn't much change in HDL levels. If you come to this other end, this is gamma GT, Look at how gamma GT changes with increase in BMI across the different participating countries. And you'll agree with me, if you're to determine a slope here, then it is quite variable. So one then would want to ask the question, how then should we consider body mass index anytime we are trying to determine reference intervals? For our study, we tried to limit up to a maximum of 35 kilograms per meter squared. But anything between 30 and 35 is obese, and one might argue, is that a true representation of health? And so one of the questions I was asked during my Viva defense was, should we have BMI specific reference intervals? I'm sure if we were to try and have BMI specific reference intervals, that would become very controversial because some of us change our BMIs depending on the prevailing either economic situations or whether or not you decided to exercise. And I'm sure during this time of COVID, depending on your particular circumstance, you may either have increased your BMI or lost your BMI. So having given you these very long stories, what do our reference intervals look like? So the first paper I published on reference intervals around complete blood counts basically mirrors what has previously been published. And I will not pretend that what I present is actually very new information, because we know for a fact that red blood cell counts, hemoglobin, and even hematocrit differs significantly between males and female adults. I've already talked about how our neutrophil count is lower compared to Caucasian populations, and indeed, we've replicated that in the study. Perhaps the only slight difference is our platelet count. Most laboratories report one reference interval for both males and females, but consistently I've seen in a number of studies, women appear to have higher reference intervals for platelets compared to men. And one of the reasons we think this is the case is because women have lower levels of iron, and we know that iron is potentially an inhibitor of thrombopoiesis. This is data from a study that was conducted in the 4 East African countries that I had earlier mentioned and alluded to. And the reason I pull it up is that insofar as I've shown you what I derived from 4 urban counties, if you look at this data from Kenya, this is Kilifi and KNH, which are the 2 participating, well, actually 2 of 3 participating sites from Nairobi. One thing that will strike you is what I am highlighting here. Now, on this plot, the white is female adults and the blue is male adults. And you can clearly see of these towns here, the town which had the lowest hemoglobin level was Kilifi. KNH, and if you read this paper, many of the participants were either master's students or nurses. Not surprisingly, the hemoglobin levels were a bit higher. But this highlights the fact that even within a country, you might have very different reference intervals. And to the point that Professor Mayo had brought up earlier, what defines normality or what is normal is quite relative. The complication arises is when I try and convince you that I recruited a healthy population and got a lower limit of a hemoglobin around 8. No obstetrician, for instance, would accept that a hemoglobin of 8 will be normal, even if the woman is otherwise walking around and enjoying life. And we can discuss that further during the Q&A. This the publication we published last year on chemistry and amino acid reference intervals. And again, I'm highlighting what appears to be fairly consistent. This higher upper limit of normal for total bilirubin. This has been published from studies in Kericho, from Western Kenya, and appears to be fairly consistent. I am of the opinion that we probably have a higher prevalence of one of the common causes of asymptomatic unconjugated hyperbilirubinemia that we call Gilbert syndrome. And one of the studies I'm planning to do is to look at the prevalence of this condition in our population. This is a study again that I had alluded to earlier, done in 4 East African countries. And again, I'm just showing you that if you look at this upper limit for total bilirubin, it is fairly consistent, especially in males. Immunoglobulins, again, when we compare the upper limit of our immunoglobulins and also CRP here, CRP, we got an upper limit of 14. Normal upper limit for normal CRP is around 5. So it appears that there was some background inflammation in our population, maybe due to either infections or non-infectious causes like metabolic syndrome. We really do not know. But clearly despite all our attempts at recruiting an otherwise healthy population, there was clear evidence that significant proportion had what appeared to be like some background inflammation. The question is that normal? What does it mean? Should we adopt this as our normal for CRP and tests like immunoglobulins? Again, this is consistent, has been demonstrated in other East African countries. So there is something about our populations in East Africa and even South Africa that our inflammatory markers appear to be higher compared to Caucasian and Asian populations. Now, one of the things that we did during this global study on reference intervals was try and compare reference intervals across countries. But what we found, for instance, we did compare even amongst Africans. So we compared our reference values in Kenya to reference values from Black South Africans and just looked at how they changed with certain sources of variation. And here what I'm showing you is uric acid and how comparing the green, which is Kenya, and the blue, which is South African, Black South Africans, you can see even people of a similar race, the variation with change in BMI is quite different. This is for males, and this is for females. Again, this is for CRP, and these are log CRP values. You can see how these differ. They seem to converge as BMI increases, but what you'll agree with me is that there's a difference in how these parameters are changing with change in BMI. So despite being of the same race, we do have these differences within races, and that this does not surprise me at all. We always say that Africa is the most genetically diverse continent. We have more genetic diversity than any other race, and hence, therefore, when we try and describe populations based on race, even if it's for medical reasons, we might actually be doing a great disservice because race is a very poor surrogate for genetic diversity. We did attempt to compare our reference intervals with those from South Africa because we both had all our samples analyzed in the same lab and we applied the same criteria for inclusion and exclusion. And what surprised us is what I have highlighted in yellow, that we had significant differences for certain tests. So if you look at LDL cholesterol, for instance, our LDL cholesterol values appeared to be higher for both males and females compared to the Black South African population. And the same applies for tests like sodium. That was quite surprising. We're actually quite surprised with the very low sodiums for the South African population. I pointed this out to them and asked them whether are they sure this was not a pre-analytical issue with the samples. They said it is not. But we agreed that we need to do further studies because you'll all agree with me, a sodium of 129 cannot be a definition of normal. Look at the CRP, whereas we thought that we had very high CRP levels in our population, the South Africans actually had much higher levels. And yet they, just like us, recruited what we thought were healthy population. So I hope I have been able to highlight for you that reference intervals are not as easy as one would want them to be. And if I had known what I know now at the beginning of my PhD, I probably wouldn't have done a PhD on reference intervals. I thought I was taking a shortcut, but clearly the more I knew, the more I got to know, the more I realized how little I actually know. The other controversial topic around normal ranges is arguments between what is more important. Is it reference intervals or clinical decision limits? You'll ask me, what is the difference? To diagnose diabetes, for example, the American Diabetes Association says you need to use either a fasting plasma glucose or carry out oral glucose tolerance tests or perform a hemoglobin A1C. Now, the cutoff that is provided for diagnosing diabetes based on a fasting plasma glucose is 7 millimoles per liter. Now, 7 millimoles per liter is a clinical decision limit. It was not derived by getting a healthy population, asking them to fast for 8 to 14 hours, collecting samples and defining what their range is. This cutoff was based on ability to predict the development of moderate diabetic retinopathy. So basically, it's a cutoff that predicts a specific outcome, hence the terminology clinical decision limit. However, with the study we did, we tried to come up with a reference interval or a normal range for fasting plasma glucose, and this is what we derived for those aged 18 to 45 years of age, and this for those aged 46 to 65 years of age. And you can see if truly our normal range for those who are above 46 years of age is 7.3 in terms of upper limit, then a number of individuals whom I would be considering normal or having normal fasting plasma glucose would actually be diagnosed as having diabetes based on clinical decision limits that are given to us by the American Diabetes Association. So there's a long argument about what then should we use when coming up with these definitions of diabetes or hyperlipidemia. Should we base them on clinical decision limits or on reference intervals? Now, I've taken quite a bit of time trying to take you through what I have been engaging in the past few years as far as reference intervals, and just giving you a taster of the complexities involved in this reference interval science. I continue to pursue this path, and one of the things I'm currently planning to do is to engage in a study in Kilifi and trying to define reference intervals or normal ranges in a pregnant population, in women of reproductive age, and at the same time, try and see whether we can come up with clinical decision limits that actually predict adverse pregnancy outcomes. And just try and figure out and evaluate how these operate in both an urban and a rural population. So I've spent about 45 minutes, hopefully not boring you around this topic. But what I would like to emphasize in summary is that normality is relative, as Prof. Amayo aptly put it. And I hope I've convinced you that it is not something that is easy to define. Second point I would like to emphasize is that as a laboratory and as clinicians, do not adopt reference intervals blindly. Question your lab, ask them what is the source of the reference intervals that they're using and whether they are appropriate for your population. I hope I've convinced you that indeed race is a poor surrogate for genetic diversity, and that finally, given what I have shown you about BMIs and how BMI affects reference intervals, we perhaps need to explore other potential sources of variation in reference intervals in an attempt of trying to make reference intervals more specific. After all, we are all moving towards the era of personalized medicine. So with those many words, I would like to hand it back to the chair of the session for any questions, discussions, or clarifications. Over to you, Prof. Amayo.
Thank you very much, Dr. Omuse. And your summary slide aptly indicates what the discussion is all about. And we are open to receive now inputs from the audience in the way of question and answers and comments. And let me open this QA. Okay, my glasses here. Can you see questions? Wow, this technology is. Geoffrey, can you see the questions? Okay. Now let me see. Okay. Okay, there is a comment. There is a comment from an anonymous attendee, which reads that thank you for this enlightening presentation. And I like to think about normalcy may be association with risk of overt disease. For example, anthropometric trends in children in the NHANES studies have shifted over the last 3 decades. How can one control for such shifts versus health? Yeah, the NHANES studies which are on population-based health studies where they collect also samples, and in addition to anthropometric measures, that there are anthropometric trends in the children which have been found in the NHANES, meaning populations change. Geoffrey, so what you found, I think the implication is what you found in the study which we did about 4 years ago may not be the current situation. So how do we control for such shifts? So the reference values for life.
Thank you, Prof, for that question. And it's not an easy question to answer, because when you have these shifts and trends happening in the community, the questions then that arise are, one, do these shifts or trends depict variations in what we would consider normal, or could they be early indicators of subclinical disease? And so these trends and shifts happen. So for instance, BMI. If you look at data on BMI or in sub-Saharan Africa, it has had this increasing trend over time. The question would be then, do we need to redefine what a normal BMI is for our population, or should we look at this change in BMI as an indicator of subclinical disease and potentially ill health in the population? So it is not an easy question to answer. One needs to look at these shifts and trends, and then look at the overall health status of the population and ask yourself, is it truly a representation or a variation of what we would agree is normal, or could it be an indicator of disease? So I don't have a yes or no answer, Prof. But one has to look at that data in that context. Over to you.
Yeah, thank you very much. I fully agree that changes may reflect a decline in the health status of that population. So a decline would not now say that now this is our health, that we are healthy in this situation when we are all diabetics, if we may use that extreme.
Yes.
Yeah? So I think the data has to be interrogated, like the way we have found that there has been an increase in obesity in children in our population. So that would reflect a decline in the overall health. Yeah, thank you. So Odongo Odio is asking, as an obstetrician, gynecologist, well, where has it gone? This technology is, yeah, as an obstetrician gynecologist, is the altitude a factor in values like HB? And he says we really, as having worked in several regions in Africa and Kenya, we really depend on the values that are given to us as reference intervals. So okay, actually he's encouraging you to shoulder on, but the main question is altitude a factor in HB?
Yes, so altitude is indeed a factor. It is, so altitude is a factor. This has been well described across many countries, even in Kenya here. We know that people who live along the coast generally have lower hemoglobins compared to people who live in the highlands. And people in the highlands generally have a higher hemoglobin because it is sort of compensatory. It's a physiological response to the reduced oxygen, as it were, at higher altitudes. And I've even joked with people and said that I would really love to carry out a similar reference interval study in the highlands where our athletes train, because oftentimes we hear that our athletes are being accused of doping, and the first indicator apparently for doping is very high hemoglobins. If you look at the data I showed you, our upper limit of normal for males was around 18 grams per deciliter, which is quite high. And actually, for the hematologists in this presentation, they will tell you that the hemoglobin of 18, they start thinking about polycythemia. Nairobi isn't as high as some of the places in the highlands, like 10, and there's a likelihood that the people who train there have much higher hemoglobins, and possibly when they're being suspected of doping because of having very high hemoglobins, it would be good to know what is normal in that area. So yes, altitude does impact on hemoglobin. For me, what is more concerning is actually the low hemoglobins found at the coast. Are they actually representative of healthy women, especially, or do those women have, say, iron deficiency anemia, and do they need to be treated? And I really don't know the answer to that question. It's something that we're currently trying to study. Over.
Okay, thank you very much. Dennis Koske has raised his hand. If the administrator can enable him to ask his question. David Koske. Administrator, is David Koske able to talk to us? Is Koske able to unmute? Okay, while while our support system is kicking in, I will read what is in the chat. Francis Kigo is asking, what is the role of indirect methods of deriving reference intervals?
Okay,
just
so
indirect methods.
Yeah, so perhaps for those who are not familiar with indirect methods, so when you set out to determine reference intervals by going through what I've tried to describe, which is deliberately setting out to recruit a reference population, collecting samples, analyzing, and coming up with the reference intervals, those are direct methods. Indirect methods are where you use data that was being collected, not necessarily for the purpose of defining reference intervals, say routine data for, say, checkups, and then using that data to derive reference intervals. So indirect methods are being encouraged in certain jurisdictions, especially countries like Australia and New Zealand. They've published a lot using indirect methods. They are cheaper. They don't require you to go out and try and recruit individuals. However, the challenge becomes that one is the issue of standardization of your analytical methods, especially if you're using data that was run across different laboratories that perhaps may be using different analytical methods. Then how do you then control for inherent biases of the assays? That's number one. Number two, how sure are you that the people that on whom these tests were done would actually meet the definition of healthy, and I say healthy in quotes. There are statistical approaches to try and sort of clean up data by excluding outliers, to try and sort of tease out who then would be an ideal population. Indirect methods have also been used in countries like Japan. And the reason why countries like Japan are able to give us a lot of data using indirect methods is that annual checkups are quite common, even within the public health system in Japan. So by and large, one can be confident that the large bulk of the data available in their databases actually are from people who we would otherwise consider as healthy. So in the absence of anything else, indirect methods can be considered with the caveats that I have just provided. Over.
Okay, thank you very much, Geoffrey. And I think we can also use the medical health record to scrutinize the health status of the individuals whose data is being used to provide sort of a posteriori approach to identifying the reference population in the indirect method. Robinson Duarte is asking, is it possible to have the Kenyan reference ranges available for our labs? So he's asking, can you share what the data that was obtained with the labs in Kenya? Geoffrey, do you want to share the output of your research to be used in labs in Kenya?
Absolutely. So fortunately, we published our data in open access journals, PLOS ONE. So you can just Google and you'll be able to download the papers I've made reference to free of charge. So they are available, and any lab is free, or anyone is free to download. And what I would say is that before you also adapt them, you can go through the small process of verifying, just to be sure that they are appropriate for your population. Because as we have highlighted, even within the same country, you might have some slight variations across populations.
Thank you very much. And thank you for reminding us that you need to verify. If it is not your own data, kindly verify. The sample size, if those perhaps who joined a bit late, the sample size for verification is only 20. 20 supposedly healthy individuals are sufficient for verification. Now, administrator will help us. There are 4 people whose hands are up. If the administrator will help unmute them, then we will hear from them. Yeah. Meanwhile, I'll continue reading. Administrator, help us with the hands, with those with raised hands, so that they can ask their question. Okay, maybe one person has been unmuted. Okay, so Dr. Adesola is asking, most of these references are not in use yet in our hospitals. We still use the published ones from the internet. How do you implement local data? I think you have answered that by answering the previous question. Dr. Chandabuka is asking, what is your comment on assigning reference ranges for particular groups such as smokers? And his question is coming from the carcinoembryonic antigen, where we have reference ranges for smokers and non-smokers. So should you expand that to other analytes?
That's a very interesting question. Well, I think CA, the reason for having different intervals for smokers and non-smokers is because it is known that smoking actually affects your carcinoembryonic antigen levels. Now, just trying to imagine someone carrying out a study where you include smokers. Of course, we did in our study, but put a limit of 20, a maximum of 20. I think it would be good to explore. I haven't explored smoking as a source of variation, and how that would impact other tests. And so I will leave it at that. I think it's interesting. I do have data that we collected as part of our study for those who are smoked a bit. And I can try and do that analysis and see to what extent smoking affected our reference intervals. But of course, I am on the bad wagon that smoking is bad for your health. So I perhaps would want to discourage people from smoking. Over.
Okay, so maybe then you can provide data to show how bad smoking is from that analysis. Yeah, it will provide science to the view.
Absolutely.
Yeah, so you may want to do that. So somebody is picking up on the fasting blood glucose. There's the issue of normal cutoff for fasting blood glucose of 7.8, but for Kenyans is of concern, as some people labeled as having diabetes. That cutoff we use is 7.0 and may not be having diabetes. Kindly comment.
Yeah, I think I would really love to comment on that so that the correct message is taken from this presentation. So I did mention the difference between a clinical decision limit and a reference interval. So on this question of fasting blood sugar, I would highly recommend we stick to the clinical decision limit, because the clinical decision limit has been shown to predict specific outcomes. And I did mention moderate diabetic retinopathy, which is sort of a macrovascular complication of diabetes. So since values above 7 millimoles per liter have been shown to have a direct link to a specific clinical outcome, then in the clinical space, they're more appropriate than just reference intervals. Because I'd already alluded to the fact that many things may contribute to variations in reference intervals until such a time we are also able to carry out longitudinal studies and actually derive cutoffs that best predict outcomes that we are interested in. I think until that time comes, we have no choice but to adapt clinical decision limits from other jurisdictions where they've been able to carry out robust studies and give us this data. Over.
Thank you very much for emphasizing that. Now we have participants who have raised their hands. Are they able to unmute by themselves? Is the administrator here? Is Dr. Kinuthia's team? We have 5 participants who wish to ask questions.
Yeah, Prof, actually they have been unmuted, and it seems it may be more in error, because when they are unmuted, they don't ask.
Oh, okay. Yeah, so they just touch that button.
Yes.
Okay.
So I would suggest you just continue with the Q&As.
Hello, Prof, are you still there? Have we lost Prof. Mayo?
What are you recommending as the way forward?
Prof, I missed
the first part. You just do Q&A.
Okay, yeah.
Yes.
Okay, thank you.
Yeah.
Prof,
so Geoffrey, yes.
I think you went to mute for a while.
Oh, okay, I'm saying there is a question here on what is the way forward for normal ranges in view of the challenges of getting these normal ranges for our laboratories.
So I think a good starting point is reviewing studies that have been published from populations in sub-Saharan Africa, or from populations in your country that are similar to where it is, whatever jurisdiction you reside. Then once you identify this, have a look at them and at least try and verify whether they are appropriate for your population. I must emphasize that the population variations, by and large, for most analytes are not that huge, but for specific analytes that I have highlighted in my presentation, the differences could actually result in really misinterpreting data and one ending up making wrong decisions based on wrong interpretations. So I think there is data that has been published, like East Africa. I think what I've published just adds to what has already been published. We perhaps were able to sort of try and select for a subjectively healthy population better than maybe some of the previously published papers. So I think a good starting point is to look at what has been published and just see how that differs to what the manufacturers are giving you. Over.
Okay, thank you very much. Then somebody is asking, does hemoglobin decrease or vary with age, particularly in healthy women? Yeah, healthy women, specifically between 40 years to perimenopausal.
So
did you note any variation with age?
Yes.
Among healthy women?
There is variation with age. Actually, as you approach menopause and beyond menopause, what happens is that your hemoglobin goes up because of increase in androgens and reduction in estrogens. And we know that androgens play a role in promoting hemopoiesis. So by and large, women above the age of 45 will have higher hemoglobin levels than women below the age. The other thing is that women below the age of 45 are generally women in the reproductive age. These are women who are having the menses. These are women who are childbearing and indeed have higher losses of blood compared to women who are in the perimenopausal and postmenopausal period. Over.
Okay, thank you very much. Then somebody is asking, most LDL cholesterol and total cholesterol values appear high even in healthy populations who come for normal medical check-up. What's your take? LDL cholesterol and total cholesterol. And here we use the clinical decision limits. What's your take?
So thank you. And thank you for that question. Indeed. So just like glucose, and even tests like hemoglobin A1C, cholesterol or lipid basically are some of the tests where we generally encourage the use of clinical decision limits and not reference intervals. And why is that the case? It's because we usually look at lipids in terms of determining cardiovascular disease risk. And the lipids are just but one component in the when you're looking at criteria for determining cardiovascular disease risk. So you'll find that we often talk about scoring systems, so things like Framingham risk scores. And the reason for this is that the same level of cholesterol can have different implications on different individuals. So the same value, for instance, in someone who is a smoker, someone who's had prior history, for instance, of cardiovascular disease, or someone who is obese, would have a different, would spur different intervention from someone who is otherwise healthy, is slim, is not a smoker. So interpretation of cholesterol and LDL is contextual. So you don't just focus on the fact that it is elevated, you focus on looking at other parameters that contribute to cardiovascular disease risk. And that is why we don't talk about normal ranges. No laboratory should publish or provide so-called normal ranges for cholesterol and LDL. They should provide clinical decision limits that tell you that whether you're borderline or high risk, moderate risk, or low risk, and provide a rider that those need to be interpreted in context based on the other known risk factors for cardiovascular disease. Over.
Thank you very much, Geoffrey, for that response. Now, then, in the same vein, can you then comment on vitamin D? vitamin D, the reference values that I use for vitamin D.
I think for starters, vitamin D is probably the most controversial laboratory test after the COVID antigen test. I think because I think what is a normal vitamin D is a very philosophical question. People, and we know that various societies like the Endocrine Society or the Institute of Medicine from the US have defined ranges, especially in adults, that sort of stratify one into three categories of sufficient, insufficient, and deficient. And if you look at the genesis of those cutoffs, one of the studies that was carried out and from which that resulted in the derivation of these values, I think it was a study in Germany where they actually recruited people involved in road traffic accidents who came to the accident and emergency departments. Blood samples were collected, and unfortunately, a number of them died. And subsequently, they were able to do postmortems, including bone histologies, and they were able to correlate values and appearance of the bone, and basically determine what levels then correlated with a normal bone that had deficient mineralization. So that is sort of the genesis of the so-called cutoffs that we broadly use. But you do realize that those were derived, first of all, in Europe, and there are many differences between we in the African continent and people in Caucasians in the European countries. So the differences include from our skin color, from how much sun we are exposed to, our diet. So we really don't have any data from the African continent that has sort of tried to verify these clinical decision limits. What we have are studies that have been carried out that have tried to correlate vitamin D levels to things like calcium, phosphate, or PTH, and therefore using calcium, phosphate, and PTH as sort of surrogates for functional vitamin D deficiency. We carried out a study at Aga Khan with Dr. Elizabeth Kagotho, who made a presentation here on Tuesday, and we found that a vitamin D value of around 30 actually sort of correlated with any values below 30 correlated with a divergence of PTH, meaning a sudden increase in PTH levels, suggesting that values around below that then would correlate to a functional deficiency. So that is the best we can do in terms of surrogates. And in the absence of anything else, then we are sort of forced to use what has been published as clinical decision limits. But we know now that vitamin D is important for much more than just bone health. It has important functions in immunity, and we do not know what levels of vitamin D actually confer sufficient immunity to protect us from certain diseases. So it's an extremely controversial topic. I think Francis made a presentation on the same. I think we could engage in certain in more dialogue around it, but there's really no easy answer to that question. Over.
Thank you very much. Thank you very much for that, Geoffrey. Now, somebody is asking whether we should also get our own data on anthropometric. I think they're alluding to the BMI issues. So let me read the question. It is not entirely a clinical lab, but do we need to have our normal values for anthropometric measurements and cutoffs to define who is overweight, obese, etc.? And maybe our cutoffs are different. So extrapolating from the lab reference interval evaluation now to anthropometric.
Yes.
What's your take?
I think so. I think we need to. If you look at the history of BMIs, BMIs are actually not developed for diagnosing anything. BMIs are basically an epidemiological concept that was basically used to stratify populations and try and define risk in the population. It's actually not used for diagnosis. That when we say now if you have a BMI above 25 and people are calling you overweight, that was not the intention of BMI. Having said that, it's very clear that BMI varies across ethnicities and races. The Asians, for example, for the same BMI as an African or a Caucasian, are at a higher risk for cardiovascular disease. And it's actually been shown that even within what would ideally be defined as a normal BMI 19 to 24, you have Asians who are in that category and are still high risk for cardiovascular disease. And not just that, any slight increment in BMI has a higher change in terms of higher increase in cardiovascular disease risk in Asians compared to Africans and compared to Caucasians. So basically highlighting the fact that even the concept of BMI sort of needs to be domesticated to ethnicities or races or different populations. So I do agree with that observation from whoever asked the question.
Thank you very much. I don't know whether Dr. Barasa, I saw something flashing from, Anne, did you want to say something? Or maybe I was imagining.
No, Prof, I was just getting rid of the answered questions.
Oh, okay, thank you very much. Okay, so then do we have any unanswered questions since you're helping me, Anne?
No, they're all done.
They have all been attended to.
Yeah.
So once again, I wish to thank Dr. Omuse most sincerely for this very enlightening presentation. To me, it's an important topic because that depends can be a matter of life and death for some situations. So my hope is that we are going to consider reference ranges in the right context. And once again, on behalf of the laboratory fraternity, we want to thank all of you who have stayed on through this talk. We hope that you have taken home something which will be useful for your patients, and those in policy will be useful for policy development. So we welcome again next week. I think on the screen, you already have what is going to be the webinar for Monday from 2 to 3. And please join in. There is a lot to learn, and it is all for the benefit of healthcare in Kenya. Thank you, KNH, for hosting us this week. We don't take it for granted. So thank you very much and have a nice weekend.
Thank you very much. Bye-bye.